Hello, I'm Dr. Shane Riley, and I'm an orthopedic surgeon at GGC Western Kentucky Orthopedics. I'm here to educate you a little bit about carpal tunnel syndrome and cubital tunnel syndrome and some treatment options, as well as a new surgical option for carpal tunnel release that allows for a quicker recovery that I offer. Carpal tunnel syndrome is a compression of the median nerve at the wrist by the transverse carpal ligament, and it causes numbness, tingling, weakness, and sometimes atrophy within the hand. Cubital tunnel syndrome is a nerve compression that can occur at the elbow by multiple structures around the medial aspect, as well as sometimes bone spurs or deformity of the elbow from previous fractures, and that can result in numbness, tingling, weakness, and atrophy of the hand. There are some other disease processes that might cause similar symptoms, such as diabetes, cervical radicular symptoms, which can be coming from nerve compression at the neck. Alcoholism can cause neuropathies that can cause similar symptoms, thoracic outlet syndrome, and brachial plexus injuries that can present similarly. Some patients are more at risk of developing carpal and cubital tunnel syndrome. These include females, pregnant females, obese patients, patients with diabetes, hypothyroidism, chronic kidney disease, elderly patients, patients with repetitive job movements that can cause compression on the median nerve and ulnar nerve. Carpal tunnel symptoms include numbness, tingling, pain in the median nerve distribution, as well as atrophy of the hand and weakness. Cubital tunnel syndrome presents with numbness, tingling, pain within the ulnar nerve distribution, atrophy, and weakness of the hand as well. Carpal and cubital tunnel syndrome are diagnosed generally by your physician on physical exam with special tests for each individual nerve process. Also, insurance companies are requiring an EMG NCV, which is an electromyography or a nerve velocity conduction test. And what that does is it tests the electrical activity of the muscles and the nerves and can differentiate whether the deficits are coming from the neck, the elbow, the wrist, or some other disease process. There are conservative treatment options for carpal tunnel and cubital tunnel. For carpal tunnel, we do anti-inflammatories, corticosteroids, activity modifications, and cock-up wrist bracing. For cubital tunnel, we offer NSAIDs, corticosteroids, activity modifications, and nighttime bracing that braces the elbow in a semi-extended position to prevent hyperflexion. People oftentimes ask, how do they know if they need to have surgery? And that would occur after you failed conservative care, or if an EMG NCV shows that you have moderate to severe compression of the nerve. Oftentimes we want to try to do conservative care before surgery, but if the nerve test does show this, we want to get to it before it becomes more severe, because people who have the procedure done at an early time get better results, versus if it's more severe or chronic, you may not get that full function after surgery. There are different types of surgery for carpal and cubital tunnel syndrome. For carpal tunnel syndrome, there is an open carpal tunnel release, which is the traditional treatment, or there's the endoscopic carpal tunnel release, which is the procedure that I offer, and it's new to this area. However, I've been doing it for many years. With the open carpal tunnel release, you have an incision over the palm of the hand, and we release the transverse retinacular ligament, which allows the median nerve to be released from the compression. With the endoscopic carpal tunnel release, it's a small incision at the wrist, so there's no incision at the palm, and we release the transverse carpal ligament from underneath the skin, and it offers a quicker recovery for the patient, gets them back to work sooner. As far as the cubital tunnel release, there's open and endoscopic cubital tunnel release. The open is traditional, and almost all physicians in this area do that. As far as the endoscopic, there's not much data on that, and there's multiple structures that you have to release in a cubital tunnel release. Therefore, we are sticking with the open cubital tunnel release at this time. For my patients, I suggest the endoscopic carpal tunnel release for a quicker recovery and less pain. However, if a patient has had a previous carpal tunnel release and they're having residual symptoms again, or a patient has had a previous surgery on their hand and they have scar tissue in the palm of their hand, then I would recommend that they have an open carpal tunnel release. For the cubital tunnel release, as I stated before, we're all doing open cubital tunnel release at this time at our facility. Some patients wonder what to expect after surgery, and it's based on the type of procedure that you have. Most of the time, patients have instantaneous relief with this, especially if we get it before it becomes a chronic or a severe compression. And they continue to get better over a 6 month to a year time frame. Now, if you have an endoscopic carpal tunnel release, you don't have sutures afterwards, and therefore you just have a Band-Aid and a brace that you can wear as needed. It allows for that much quicker recovery. If you have an open carpal tunnel release, then oftentimes you do wear a splint for a week to 2 weeks, and you have the incision over the palm. You have palmar pain with both procedures. However, it's a much quicker recovery with the endoscopic because there's no incision there. As far as the cubital tunnel release, you will have an incision over the medial side of the elbow, and you'll have a brace that you wear for 1 to 2 weeks. After that, you can start ranging the elbow, and it's not abnormal to have some elbow pain on the medial aspect for a few months after surgery as well. The complications that are associated with these surgeries are similar to any surgery, and those include nerve damage, blood loss, repeat procedures, non-healing wounds, and possible infection. Patients that are obese, smokers, or have autoimmune disease may have more likelihood of having complications than the normal healthy patient. Unfortunately, some patients do end up having a repeat carpal tunnel syndrome or cubital tunnel syndrome, but most of the time this happens many years after the procedure. Sometimes if a patient had an inadequate release in their first procedure, they may have to have a repeat procedure, which is highly unlikely. And at this point, it would require the open carpal tunnel or the open cubital tunnel release. So today we've talking about the carpal and cubital tunnel symptoms and the surgery options, but I also perform surgeries including shoulder surgery, hip surgery, knee surgery, and fracture care. Some of my other partners have talked about these, and during our education process, I didn't want to be repetitive. However, if you have any concern about any of the conditions that we talked about, please talk to one of our physicians about this, and they can assist you with this or point you in the right direction of a physician who can perform that surgery.